Hi friends, I welcome all of you to another episode of my YouTube channel Future Midwife. Do you remember where we reached our last section? Yes, still we are in the track of induction of labor. In the last section, I explained about pharmacological induction of labor in detail. In this section, I will explain about the remaining induction of labor such as surgical induction and mechanical induction of labor. So without wasting time, we will move on to surgical induction of labor. The surgical induction procedure primarily referred to amniotomy, also known as artificial rupture of membrane. First we'll see what it is. It is preferred when the cervix is partially dilated and softened and the baby's head is engaged in the pelvis. The healthcare providers conduct a sterile vaginal examination to assess cervical readiness and fetal position. A thin sterile plastic instrument called an amni-hook or amniotomy is inserted gently through the cervix to puncture the amniotic sac. This rupture releases the amniotic fluid, which increases prostaglandin in the uterus and can stimulate contraction or enhance existing contraction. After rupture, the fluid flow is monitored. The baby's heart rate and uterine contraction are closely observed to ensure well-being and effective labor progress. Amniotomy can be done alone or combined with oxytocin infusion to induce or augment the labor. Next, we'll see the important consideration before amniotomy. Amniotomy is generally avoided if the baby is not well positioned or if there is a risk of cord prolapse. It is not recommended if the cervix is not favorable because it can lead to infection or other complication without effective labor onset. The risks involved include infection, umbilical cord prolapse, or fetal distress. This surgical method is typically part of a controlled induction process, often preceded or followed by pharmacological cervical ripening and or oxytocin administration. Here I will explain the steps of artificial rupture of membrane. First, explain the procedure and obtain consent. The healthcare provider explain the procedure, reason and risk to the mother. Also obtain the informed consent. Prepare the patient and equipment. The woman is placed comfortably with the knee bent and thighs apart, typically lying on her back. A disposable sheet is placed under her for fluid collection. Sterile gloves and an amnio hook are prepared. Assess the fetal and cervical status. A vaginal examination is performed to confirm the cervical dilatation, effacement, station and the position of the fetal presenting part. If the presenting part is not well applied or high, artificial rupture of membrane may be deferred to avoid cord prolapse. The perineum and vagina may be cleaned or swabbed. Lubrication is applied as necessary to the examining fingers. Perform vaginal examination and insert amnio hook. The examining finger is placed through the cervix to feel the fetal scalp or presenting part. The amnio hook is gently introduced into the vagina with the hook facing downward to prevent maternal tissue injury. The hook is set against the amniotic sac to create a small tear, allowing the amniotic fluid to escape. The provider keeps a finger through the cervix momentarily to check for umbilical cord prolapse, especially if a large gush of fluid occurs. Next, we have to examine the amniotic fluid color, amount and odor of the amniotic fluid are noted for sign of meconium or infection. The fetal heart rate is monitored continuously or intermittently after the procedure for at least 60 seconds initially to ensure no fetal distress. Soiled linens are replaced, a sanitary pad is applied and the woman is informed about what to expect next. Artificial rupture of membrane helps to stimulate contraction by removing the fluid cushion and releasing prostaglandin, but should only be performed when the cervix is favorable and fetal presenting part is well applied to avoid complications. Next, we'll see the complications associated with the surgical induction of labor. These are infection, umbilical cord prolapse, fetal distress, increased risk of instrumental delivery, increased risk of cesarean section, uterine hyperstimulation, pain, placental abruption, postpartum hemorrhage, and fetal injury. These complications can vary in severity and likelihood depending on individual circumstances. Next, we'll discuss about the mechanical induction of labor. In that, the first one is balloon catheter insertion. The catheter induction involves the use of a balloon catheter, usually Foley's catheter or double balloon catheter, which is inserted into the cervix to promote cervical ripening and initiation of labor. Next, we'll see the types of catheters used. These are Foley's catheter, commonly used single balloon catheter. Next is Hook's double balloon catheter, especially which is designed for labor induction. One balloon inside the uterine cavity and another will be in the vaginal canal. Now I will explain about the mechanism of action and procedure for mechanical induction of labor, that is catheter insertion procedure. First, we'll see the mechanism of action. The balloon apply pressure on the internal os and lower the uterine segment, which stimulate the local prostaglandin release, which cause mechanical dilatation of cervix. Also, fetal head will be descend and it will increase the pressure on the cervix. Furtherly, it stimulate the labor process. Next, we'll see the procedure. It should be performed under aseptic condition. Insert 16 to 18 French Foley's catheter through the cervical canal. Inflate the balloon with a 30 to 60 ml of sterile saline. Pull the catheter so balloon rests against internal os. Secure to inner thigh with a gentle traction. Leave in situ for 6 to 12 hours or until it falls out spontaneously. If labor does not start, proceed with oxytocin infusion or amniotomy. Next is the Cook's double balloon catheter insertion. It has two balloons. One should be placed inside the uterus, which is above internal os. Another one placed in vagina, which will be below external os. Provide better pressure and more effective ripening than single balloon Foley's. Usually inflate with a 30 to 80 ml saline in each balloon. At last, we reach the complications of balloon catheter induction of labor. These are discomfort or pain, infection, bleeding or hemorrhage, placental abrasion, uterine hyperstimulation, fetal distress, umbilical cord prolapse, rupture of membrane, failure to progress in labor, and increased risk of cesarean section. Keep in mind that these complications can vary depending on individual circumstances and medical conditions. So here we can wind up our today's section. With this section, I have completed the whole topic induction of labor. So in this section, we have seen many types of induction of labor. I hope all of you understood about the topic. In the next class, we will meet with another episode of midwifery topic. Till that, take care. Bye-bye.